Hi everyone, it's Dr. Lisa L. Campbell. In this video lecture, I'm going to cover chapter 4, which focuses on the steps to assigning a diagnosis code. Here are the 5 objectives for this chapter. Number 1, you should be able to describe the medical documentation that has to be present to accurately select the code. Number 2, identify and select main terms in the alphabetical index. If you have not done so, it is so very important that you take a self guided tour of the ICD-10-CM manual by using the table of contents. All right, number 3, identify modifying terms in a diagnosis statement. 4, summarize the steps in coding. And then 5, identify the guidelines that impact the steps that a coder follows when selecting a code. This video lecture is not a substitute for reading chapter 4. Let's get started. So, when we talk about the steps in assigning a code, I think the very first thing that you need to understand is that manual. I think oftentimes individuals who are learning coding miss that step, which later impacts how you assign a code. In order to properly assign the code, you have to know coding conventions. So, in the official guidelines for coding and reporting, they talk about different conventions such as C also, NOS, NEC. Very important to the coding process. Those conventions we don't add to the code, but they impact how we assign the code. Number 2, you have to have a diagnosis to code. Sometimes the provider's documentation is incomplete or it's ambiguous, it's conflicting. In those situations, we have to execute what is known as the query process. And then lastly, using both the alphabetical index and the tabular list are very, very, very important. So when we talk about the documentation, it's really as important as understanding the conventions, right? Because if the diagnoses and conditions are not specifically recorded, it's difficult to code. As a coder, you have to understand the actual forms that are in the medical record. Now, these forms are going to vary based upon if it's an inpatient encounter, if it's an outpatient encounter. It's 2025. Many organizations do have electronic health records. But guess what, guys? Some places don't have the financial resources. And so they may have more of a hybrid system where some of the records, part of the record is electronic and the other part is handwritten. And, they could do things like scan that handwritten portion into their system. Once you get out there and start working, you will see what your particular organization has in place. So, when we talk about coding from an inpatient, um, the textbook actually talks about the diagnoses are typically recorded on a face sheet. And I think that that is something that varies from organization to organization. And I personally would not code from a face sheet because oftentimes the face sheet is generated by clerical staff and not like a physician, nurse practitioner, etc. So you want to make sure that you review the meat and potatoes of the medical record. So for example, in an inpatient record, you'll have a history and physical exam. You'll have daily progress notes. You'll have orders. You'll have consultation reports. You'll have operative reports. You will have the discharge summary. And those documents are generated by the actual clinician that's seeing the patient. And in the case of a lawsuit or something, that's what they're going to pull up on the screen is that documentation. Now, with outpatients, you're going to see that that record is going to be a lot smaller, right? Because with outpatients, the patient is there, they leave the same day, they could be on what's known as observation. And so they could not formally be admitted, and they might be in a space or a bed designated as observation. Observation is like you're not well enough to go home, but you're not sick enough to be a full admission. In the outpatient record, you're going to see different forms based on what that patient is having done on that particular day. As you go through this journey, I want you to think about the fact that the diagnoses explain why the patient was at our facility today. Diagnosis codes are assigned on every visit and submitted to the insurance company. So when the insurance company gets a claim that's been coded by codes you assign, they want to know, okay, tell us something new. Why is that patient here today, right? It could be a condition that the patient has that got worse. It can be a brand new condition. But those codes paint the picture. But we need that documentation to paint the picture. Now, when you're reviewing the record, you should know any diagnoses based on findings from procedures or tests that have been ordered. But one thing that you need to know as coders, you cannot code from like an abnormal laboratory test result. The provider has to um, indicate that it's clinically significant. And let me give you an example that hopefully will make sense from being a patient. So, for example, let's say I go to my primary care physician's office and I get some labs done, some blood work done, right? So, usually what happens, I'm the type of person that likes to go very early in the morning to beat the rush, right? So, later that evening, what usually happens is that I start to get notifications from my patient portal that I have findings from my lab tests, right? And so when you open them up, it tells you these results have not been reviewed by your provider. And that's important because the provider may look at the results and say, like the computer generated report may say something is high, but your provider may say, okay, it's high, but compared to last time, it is trending down, and the patient is going to continue the treatment as prescribed. And they may say, redraw in 3 months or whatever the case may be. So, the point I'm trying to make, you as a coder, cannot just automatically code from abnormal test results. Organizations do have policies and procedures about the use of reports, and that's beyond what we would cover in a introduction course. All right, so one of the unique features about the ICD-10-CM code set, which is celebrating its 10th anniversary on October 1st, 2025, is that this system was created for purposes of granularity. Granularity allows the code set to provide a greater level of detail. And because of the increase in this granularity, Diagnoses can be recorded and retrieved in a more detailed and efficient manner. These codes are used for statistics and research. And so it is very important that we assign the code to the highest level of detail possible based on what is documented in the medical record. If it was not documented in the medical record, it did not happen. And so, one of the things that you're going to continue to hear about is the query process. We may need to query the provider to get more specificity. We also may need to educate the provider, based on something that we're seeing in the documentation. So that's granularity. Now, in addition to granularity, one of the cool features about ICD 10, which was different than our old system, ICD 9, which is 10 years old, but in ICD 10, the level of specificity that is available provides what is known as laterality in code assignment. So, in other words, for body parts that have a bilateral site, ICD 10 CM can provide the specific site. So on the screen here, you see an example of a fracture femur, and you see an option for unspecified, and then you see an option for right and left. Now, one thing I will tell you, you're probably thinking, well, how would you not know the side? Well, it could not be documented. And the provider, maybe you query the provider, they don't respond. And so you have to go with the unspecified side. That's where education comes in, where we're constantly educating the provider about the importance of laterality. Okay. Now, as we look at the concept of laterality, as you begin to execute the coding process, one of the things that you're going to notice is because this code set can go from 3 characters to 7 characters, in addition to the laterality, the code can have additional characters that identify if this is the initial encounter, the subsequent encounter, or what is known as sequela or the sequel. And so in the tabular list of ICD 10 CM, what you will find is that there is a little box that allows you to select things like initial, subsequent, or sequela. One thing that I do want to call out is if the tabular list tells you that a seventh character is required, if you don't have 6 characters that precede that seventh character, ICD 10 CM has a convention that is known as the placeholder of X that can be added to get us to the 7 characters. That is only used when the tabular list tells us that a 7 character is required, but we don't have 6 characters that precede that code. All right, so let's talk about the steps in correct coding. It is so very important that you follow these steps and that you don't take shortcuts and that you don't rush because that can lead to errors. So, the very first thing that you need to do is you go to your alphabetical index. So, let me just pause and make a reminder about something. In ICD 10 CM, the alphabetical index has 4 parts: the index to diseases and injuries, the neoplasm table, the table of drugs and chemicals, and then the index to external causes. So, what you'll find is a lot of the times you're going to be starting off in that index to that index to diseases. As we progress through the book, you'll get to see when we get to the neoplasm chapter, you'll get to see that table in use. So the main term is the active condition that the patient has. Words that describe the condition are not good main terms. You want the active process that's happening. So in this particular example, acute allergic sinusitis, the main term is sinusitis, inflammation of the sinuses. The word acute means that it is just suddenly came on. And then the type of sinusitis is allergic. So anything could be allergic, right? Anything could be acute, and that's why those are not good main terms. All right, step number two, you scan the main term entry in the alpha index for any instructional notations, okay? If you stop right now and pause the video and go to the term sinusitis in the alphabetical index, you'll actually see that there are no notations, right? That varies from condition to condition. Step number three, in the diagnostic phase that is being coded, you're going to identify terms that modify the main term. Now, in the alphabetical index, the terms that modify the main term are going to be indented over a little bit to the right. Very important that when you are looking at the main term, that you start at the beginning of the main term and that you're not looking at something that says like main term continue because you're not at the very beginning. So in the example that we're looking at, terms that serve as modifiers are chronic and allergic. So, following the main term sinusitis, the term allergic appears as a subterm. So, it's underneath the main term and it's slightly indented over. Okay. I want to remind you, you never, ever, ever code from the alphabetical index. So when you are in the alphabetical index, if there are any cross reference notes, you will take note of those and follow them if applicable. If not, the next step is to verify the code in the tabular list. So when I talk about cross references, those are things like see something else or see also. As a brand new coder, I want to make this clear for you. If you see the word see, you have no other option. See exactly what they're telling you to see in the order that the words are presented. But if they give you a see also, that's see what also is available. As a brand new coder, I recommend that you see also so that you can make a decision based on the documentation if the see also has what you need. All right, so then step five, you verify the code in the tabular list. Always, always, always. Okay. Once you get over to the tabular list, you're going to read your code from where it begins to where it ends. But also, you want to ensure that you go back to the beginning of the 3-digit category for a code to see if there are any notes. Why is this important? Sometimes they'll put a note at the very beginning of that category that pertains to the entire category, and they don't want to have to repeat that underneath each code, so they just put it at the very beginning. After you complete those steps, now you select the code, right? And you've made it through one diagnosis. So, some key points to remember: always, always use the alpha and the tabular lists when you're assigning the codes. Read the instructional notes. Instructional notes can be in the alphabetical index, instructional notes can be in the tabular list. These instructional notes can make or break your code assignment. Additionally, We know that one of the benefits of this ICD-10-CM system is that it provides a high level of granularity, specificity, and we love specificity with our codes. Medical record documentation needs to be complete, it needs to be accurate. And sometimes when we don't have what we need, we have to query the provider for additional information. All right, so combined with this lecture, as well as what you're reading in the textbook, you should really have a basic understanding of proper use of the alphabetical index and the tabular list. Now, as I wrap up chapter 4, I want to talk about encoders and computer assisted coding. So, currently, you have a physical code manual. In the workplace, we started using this automated computer software. Now, before you get nervous, the software needs us to um, to operate it because it's not perfect. So, an encoder is a system that is designed to assign diagnoses and procedure codes. But here's the deal: in order to use an encoder, you have to know how to use the manuals. One of the things that happens to coders over time as they work in the healthcare setting, when they don't have the manuals and they're just using a computer, a lot of times they get encoder dependent, right? What happens if the system is down and we have to go back to books? So you need to know how to use those books. Encoders make the assumption that you know how to use a manual, okay? Then we have CAC, or computer assisted coding. And the easiest way for me to explain what this is think of a computer program where the medical record documentation is fed into the computer assisted coding. It analyzes the documentation and it makes recommendations on codes. However, they still need to be reviewed by the human eye to ensure that the documentation supports what is coded, that the codes are coded to the highest level of specificity. So, as you think about um, encoders and computer assisted coding, one of the questions that you probably want to just think about is, what are the advantages of having this technology in place? All right. So these are the 5 objectives that you should be able to complete once you have read the chapter and have done the exercises in the chapter and the graded exercises. These are the things that you should be able to do. Thank you so much.